Hello everyone, so we can have a quick one on juvenile plantar dermatosis. Usually this is a common condition that can be confused with other things like palmoplantar psoriasis, yet it is actually very different. So as you can see in these pictures that I've highlighted, this is a patient that had a little bit of a well-demarcated plaque, scaly plaque with a background of erythema with fissures on the palmar surfaces. And in this picture, someone had something similar the palmar surface, and when you look at it, you can actually be tempted to think that, oh, maybe this may look like psoriasis, but in actual sense, it is not. So juvenile plantar dermatosis is one of the conditions that we see as a variant of atopic dermatitis, and in this case, it has also been called other names, including atopic winter feet, barefoot dermatitis, dermatitis plantaris sicca, or moon boot foot syndrome. Some people call it the sweaty sock dermatitis. The key features in this condition is that someone will have this dry, scaly, glazed and fissured plantar surfaces of the forefoot, and commonly affecting the pubertal children and associated with atopic dermatitis as well as other exogenous factors. So juvenile plantar dermatosis is a common eczematous condition, primarily seen in children, especially those with atopic dermatitis, as we've mentioned, and all those with atopic dermatitis. Like some people can have just a few components of atopy when they don't fulfill the entire criteria. That's when we say atopic dermatitis. And it can occur in pubertal children, usually over the age of 3 years of age, and oftentimes they wear shoes for longer periods of time. It has a seasonal variation whereby it most commonly seen in cold seasons like the winter, the rainy season, as well as a predominancy of it affecting majorly the boys compared to the girls. So in the pathogenesis, atopic deposition is a clear risk factor, and exogenous factors that will risk you to get this condition include wearing plastic or rubber sports shoes that cause a humid environment leading to dehydration of the horn layer, that is the stratum corneum, making it more susceptible to wear and tear. So you lose all the layers because of that hydration or that hyperhydration of the stratum corneum as you put on those occlusive shoes that are either plastic or rubber in nature. Then other things like friction can also result into the glazed or the thin appearance of the skin with cracks which form because of the xerosis that comes along with this condition. So inherently dry skin in atopic individuals is a predisposing factor. We've seen that already in a video for atopic dermatitis, where we say that xerosis is one of the key features that we see in patients with atopic dermatitis. So it can also cut across and affect the palmoplantar surfaces. And in adults who have a thicker horny layer, they usually don't get this type of condition. So commonly we see that's why it is called juvenile, because we commonly see it in children and then younger adolescents. So when you look at its clinical picture, someone will have symmetrical lesion on the balls of the feet and the toes. So that those are concave surfaces of the palms and soles, but mostly on the foot. So they will be well demarcated, shiny, reddish in nature with a dry scale, and oftentimes they crack and are very painful. So the dorsum and the interdigital spaces and the incept are typically spared because they're not in contact with the rough surfaces or with the shoes or with the environment. And then rarely it affects also the hands. So in the differential diagnosis, you can look at things that can mimic it, like allergic contact dermatitis, most likely caused by the chemicals in the laser or even the dichromate, the chromate, the dyes, the rubber, which can also give you something similar. And you can also think about other things like the tinea pedis, which is a bit uncommon in children. Usually, this one for children, it affects the interdigital spaces. So in this case, you may need to do the patch testing to make sure it is not an allergic contact dermatitis. Okay, you can also do KOH preparation to rule out any fungal involvement or any fungal implication in this case. Then this is how it will look like on the picture as I've shown you in the first pictures. You will see this well demarcated, thinned out. That is what glazed mean. Thinned out patch that has that background of erythema with fine scales, and also you can also see these fissures and cracking. Usually it is very, very painful, as you can see here as well. And you'll notice that the instep, this area that is not in contact with the shoes, is a little bit spared, as well as you see here in between the digits, it is also spared. So this is another picture to show you just the same. This is another picture to show you that just the same thing. So when it comes to treatment, most of the time this is a self-limiting condition, and the treatment is also with time. But in case it is very bad, you can now try to manage with maybe allowing telling the patient to put on cotton stockings, free or baggy shoes, so that there's not so much friction, as well as you can use emollients and the keratolytic drugs to calm down the hyperkeratosis, as well as you can also do topical corticosteroids to try and bring down the inflammation, as well as the pain that comes with this condition. So thank you very much. See you in the next video. This was one of the variants of atopic dermatitis, or in patients with sensitive skin, that we call the juvenile plantar dermatosis. Remember, every time you see it, don't think it is atopy. Make sure that don't think it is psoriasis. Make sure you distinguish it from allergic contact, as well as the fungal infections that can involve the palms and soles. See you in the next video.